Hello, let's discuss one of the most complicated, difficult cases that can present in a dental office, veneering a single dark central incisor. See this dark tooth, we ice tested it. This person had had a bicycle accident, and so I contacted one of the best endodontists I know in Dallas, Dr. Alex Flory, and I said, I hope all is well with you. This person that had the accident actually happens to be the CEO of my dental practice, as well as our teaching center card. Talked about the bicycle accident and said his upper central incisor was displaced palatally. He immediately repositioned the tooth into proper alignment. 1 week later, the tooth is discolored and tests negative to ice. It's not mobile. The adjacent teeth test positive to ice. I wanted to be sure I was proceeding with ideal treatment. Is the protocol simply to perform endodontics followed by internal bleaching if needed, or is there another step prior to completing the endo? Dr. Flory said the extrusion luxation he suffered causes immediate paresthesia of the pulp, which may last a few weeks. Because of that, pulp tests right now are not very reliable. Depending on how much the tooth was dislodged, complete ischemia may result, and the pulp will become necrotic. But one can only be sure later. The discoloration in this case comes from blood out of the vessels. It looks pink, and that also may be reversible. Some pain to percussion is pretty common at this stage, as well as some mobility. I would wait another 3 weeks and perform all tests and check discoloration again. If tests are still negative, meaning the tooth is not sensitive to cold and hot, and discoloration persists, perform conventional root canal, but instead of completing in one visit, apply calcium hydroxide for 1 and 3 weeks. That will help scare away any clastic cells and prevent future resorption. If discoloration persists, internal bleaching is very favorable, and in his case, since the discoloration is caused by blood, easy to get rid of. I hope that helps. What I did in this case was I tested the tooth again 3 weeks later. It was still negative and performed endodontics. Before the endodontics, I placed calcium hydroxide in the pulp and left it for 3 weeks. Then I came back and finished the endodontic. So ice test 3 to 4 weeks later, the tooth was still negative to the ice test. No sensation, still dark. So I removed the pulp, did the filing, put calcium hydroxide in the canal, left it for about 3 weeks, then came back and finished the endodontics. So this is after I finished the endo, and you can see after the internal bleaching, I thought, gosh, I'm a genius. That tooth is lighter, actually, a little lighter than the adjacent tooth. So I thought, case closed. But slowly the tooth got darker. And in 2023, this is 5 years later, you can see the tooth is dark. Now this is before anything was done, and this is after we finished the case, and I'm going to show you how we got to this point. So you can see it was darker again in 2023, and this is the final result. This is the final. So I talked to Dr. Flory again on the phone and said, what's with the tooth getting dark again? And he said, sometimes that just happens and nobody really knows what it is. You can internally bleach the tooth again and see if that does it. Well, I've changed my protocol after this tooth, because any tooth I've done before, internally bleached before, to my knowledge has stayed bleached. And so I always fill the chamber with a real light composite. So what I'm doing now, if something like this happens, I'm filling it with IRM and then finishing it with composite. So I could take the IRM out again. If you fill the chamber with composite and the primer adhesive goes into the dentinal tubules, you can't remove the composite from the dentinal tubules to bleach it again. Our only option is to restore the tooth. Now the other teeth are healthy and a nice shade. So we really wanted to just restore that dark tooth. Well, that is a very difficult assignment. I'd much rather restore 10 upper anterior teeth, but we thought we'll take this on. Again, this gentleman is the CEO of our dental practice and our teaching center, so we thought this would be a good case to see if we could do it. So I first took a shade of the dark tooth, then I took a shade of the adjacent tooth, anesthetized the teeth. The only reason I anesthetized it was because of the gingival tissue. You probably don't need to anesthetize the tooth since it's had endo, but just to be sure that everything was comfortable. Apply topical anesthetic. This is a provisional restoration tray. We try that in. This is fast set blue mousse. Have the patient bite down into that. We'll use this to fabricate the provisional restoration. So I'm going to prep this tooth just like a veneer. You know, for a veneer, you want to reduce the incisal about 1.5 to 2 millimeters, and you always want to include the interproximal surfaces, especially if you have a dark tooth. If you don't, you'll have dark shine through. So I'm going to prep the interproximal, the incisal, and the facial. I normally prep about 0.5 millimeter. In this case, since it's a dark tooth, I'm going to prep about 1 millimeter or so. You're still in enamel, but I want to give the laboratory technician enough space to place opaquer and block out the darkness. Just being careful not to cut the adjacent teeth. You've got to change these burrs pretty frequently because especially on the tip, the diamonds wear out very quickly. I like this burr because it's straight. It doesn't chamfer or bevel. And so you get a straight shot from the incisal to the gingival. Then I'm reducing the incisal edge 1.5 to 2 millimeters. And again, I'm going to reduce the facial about 1 millimeter to 1.5 millimeters. Still in enamel, but enough room for the technician to place opaque to block out the darkness. I told the technician to charge me double the normal fee because this is such a difficult case. It's hard for everybody. You can see the darkness. This is just a coarse barrel diamond. Be sure the line angles, the facial, interproximal, are rounded and the facial incisal are rounded. Now the incisal palatal line angle is not rounded. So I'm just finishing the interproximal with a mosquito diamond, round the incisal interproximal line angle. The only line angle that's not rounded is the incisal palatal and the interproximal palatal. Now I'm coming back with a chamfer diamond, and I want this margin to be chamfered a little deeper than I would normally make a veneer margin because I want to block out the darkness. I'm still in enamel though, and how far subgingivally am I? About 0.5 millimeter. That's plenty. You don't want to ever invade the junctional epithelium, so you want to keep the margin in the sulcus. The sulcus of a maxillary anterior tooth is normally about 1 to 2 millimeters. So figure out how deep the sulcus is, and you want to stay in the sulcus. And I generally like to go about halfway into the sulcus, so that's usually about 0.5 millimeter. You do not want to invade the junctional epithelium. That's the attached gingiva. If you prep past the floor of the sulcus into the junctional epithelium, you'll invade the biologic width and you'll have redness, inflammation, bleeding, swelling of the gum tissue. So never invade the junctional epithelium. Do not prep below the floor of the sulcus, and prepping about halfway into the sulcus is ideal. So it's a little more aggressive prep on this tooth since we've got the darkness, but I'm not invading the junctional epithelium. Don't prep past the floor of the sulcus. Stay in the sulcus. About halfway into the sulcus is normally about perfect. So rounding the facial interproximal line angle and the facial incisal line angle and the incisal interproximal line angles. But this line angle, the incisal palatal line angle and the interproximal palatal line angles are 90 degree. You don't round these line angles. They're 90 degree. Every other line angle is rounded. So you can see I've reduced this tooth about a millimeter and a half. It's just a shofu disc to final polish. So now we're going to select a shade, and I'm going to select a shade of the adjacent teeth, and I'm going to get a stump shade here, and then I'm going to select a shade of the adjacent teeth. This is a wax up model, and I wax it up a little thicker than the tooth, so I've got enough thickness of the provisional restoration, the bisacrylate, to work with. If you don't wax it up a little bit thicker, then that provisional, the bisacrylate provisional, is thin like toilet paper and it's very hard to work with. So always wax up the tooth or teeth being prepared for veneers about a ½ millimeter thicker than the tooth. So this is the provisional restoration. This is bisacrylate. Wet the tooth first. Wet it soppy wet. Squirt the bisacrylate on the tooth and into this matrix. You're going to apply some retraction cord. This is 00 gingivplane, and you only apply the cord to the facial interproximal line angle. Don't apply it through the interproximal. If you do, you can strangulate that tissue and lose the papilla. Let that set a little while. So this is a reversible hydrocolloid impression. If I'm only prepping one tooth, I always take 2 reversible hydrocolloid impressions. If I'm preparing 2 or more teeth for crowns or veneers, I take a polyether with custom tray and a reversible hydrocolloid impression. I always take 2 impressions. Why? Number one, you can use the second impression for the solid model to perfect the interproximal contacts. Number two, if there was any question about any margin or any part of the prepared tooth in the stone model, I've got another fallback model from another impression to look at. I don't ever want to have to make that phone call and say, Miss Jones, I'm so sorry the impression wasn't, there was a part of the impression that wasn't right. You've got to come back. I've got to remove those provisional restorations. I've got to re-anesthetize you and retake the impression. I'm just not going to have that happen. So I suggest always take 2 impressions just so you sleep well. I'm marking the interproximal contact on the provisional, and I'm doing this while the first and second impression are setting. I'm trimming that, and this provisional technique is very, very accurate. There's always a little adjustment though. You see how deadly accurate that impression is. So before you place a reversible hydrocolloid impression, you rinse the teeth with warm water. Cold water makes it set, running through channels in the tray. Hot water makes it unset. So you always, this is warm water in the plastic bottle. Squirt that on the tooth and in the tray. This gentleman already had a night guard, so I'm adjusting it so the night guard doesn't pull the provisional off the tooth. And there's the, again, very, very accurate. I'm going to take an occlusal restoration record, probably don't need it, but just to have it. His bite, his occlusion was not ideal. You know, sometimes somebody's occlusion is so far off you can't adjust it into centric relation occlusion. You'd have to do too much to the teeth, endodontics, and really damage the teeth. So in those cases, I give the patient a centric relation occlusion night guard that they wear at night. And I remind them that during the day, the only time your teeth should touch is when you swallow. Go ahead and swallow. Feel them touch? Your teeth don't touch when you're chewing food, and as you go through the day, they shouldn't touch. You shouldn't go through the day with your teeth clenched together. So remind them the only time your teeth should touch is when you swallow. So I encourage them as they go through the day to hum. I say, don't make that sound. If you're with a lot of people, they'll think you're crazy. But do the motion of humming, lips together, teeth apart. So during the day, you're not clenching your teeth, and at night, you wear your centric relation night guard. So those people should not develop a TMJ problem or myofascial pain if they'll do that. So I'm finalizing the provisional, and this is just flowable composite, 3M composite flowable. When you place flowable at the margin, you want to be sure to wet the tooth, but be sure the provisional is dry. So wet the tooth, but be sure the provisional is dry. And then cure it, and then I'll come back with this fine flame-shaped diamond and not touch the tooth, but do the final contouring with the provisional in the mouth. And you could contour it right on the money. You can also use a 12-fluted carbide burr. And once I get it trimmed, put Vaseline on the provisional. Now I'm cementing this with Olympian Crown Bridge provisional cement. Wait till the provisional cement sets up significantly. So you peel it off, you don't wipe it off. If you wipe it off, you'll get some suck back in the micro gap between the tooth and the provisional. So we don't want that. So here's the provisional. And we noticed that the provisional was a pretty close shade match. Both the patient and I was pretty happy with the match of the provisional. They got a little, see, this is the provisional, and you can see it's a pretty good shade match. You can see the darkness of the tooth. And so I squirted some of the provisional material on the lab bench that I wet, let that set, and I sent that to the technician along with photographs of the stump, you know, the prep tooth, so she, with a shade tab next to the stump and adjacent to the stump on the natural tooth, and I sent photographs, diagnostic photographs of the provisional on the tooth, and then I sent the technician that blob of the provisional material. So here's the blob I sent her, and here's the final restoration. Now, in a perfect world, I use 3 different labs. In this case, I used a lab in town and had the patient go to the office of the technician so that they could see the tooth, see the provisional restoration on the tooth, and see what it looked like for themselves. You don't have to do that. You can do it with photography, but you can see how close the technician came to matching that provisional. So here's the final restoration. That's the provisional on the tooth. So here's the final restoration on the dye model. Now this is the solid model. This is the one we use for perfecting the interproximal contacts. You don't use that for fabricating the veneer, you just use it for perfecting the interproximal contacts. So that's the die. So we're removing the provisional, polishing with pumice and water. Don't put any peroxide in the mixed with the pumice when you're polishing a tooth that's going to receive composite restoration. The peroxide that the studies show can affect the bond strength. So this is just water and pumice. And then wiping with alcohol. Now here's a hot tip: when your hygienist is having dental hygiene appointments with patients, put a little hydrogen peroxide in with the polishing paste and polish the teeth with peroxide with the polishing paste, and tell the patients your teeth are going to be lighter every time you get your teeth cleaned. So if that's a problem for you, let us know. We won't put the bleach in the polishing paste. Now guess how many patients have ever said that's a problem? 0. They'll love it. So put a little hydrogen peroxide, mix it in with the polishing paste. I'm wiping it now with isopropyl alcohol, trying the tooth in. Now you can see how close it is. In a case like this with a dark tooth, perfect is of course your favorite word, but we're looking for very, very good, just so that tooth does not stand out when the patient smiles. You can see there's some darkness in the gum tissue where the tooth is dark down the root of the tooth, but not of consequence. It really turned out very well. Then I'm wiping the lithium disilicate veneer has been treated. You can watch my video on how to treat lithium disilicate crowns and veneers. And then once we've tried it in, we're alcoholing it to get any saliva off the tooth, dry it, putting a carrier, and I'm etching the tooth just like we normally do. And since it's all in enamel, I'm going to etch it for about a minute. You really can't over etch a tooth if it's all in enamel. If part of it was in dentin, you would etch the dentin for 15 seconds and then apply the 38% phosphoric acid to the enamel and etch it for another 45 seconds to a minute. Now I'm placing the primer adhesive inside the veneer that's been treated as you treat a lithium disilicate crown or veneer prior to coming to the office. And we've tried it on, then we've alcoholed it on the tooth side and dried it. Now I'm placing primer adhesive in the veneer, and then I'm blowing that off. You want to blow it off because there's an acetone carrier that carries the primer into the dentinal tubules. And so you want that acetone carrier to go away because it could compromise the bond strength. Then I'm going to wipe the primer adhesive on the tooth, just sop it on the tooth, and then I'm going to blow that dry or blow it off. So anything that's wiggling goes away. Do not cure the primer adhesive. Let me say that again. Do not cure the primer adhesive on the veneer or on the tooth, because if there's any thickness, it might prevent the veneer from seating completely. So just blow it off and leave it on there unset. Before I seat the veneer, I'm turning the lights in the room off, and only my operatory light is on, and I turn that down toward the patient's feet so there's just a light glow on the tooth, because you don't want that ambient light to cause the primer adhesive to set up. Now, because I'm using B0.5 just to lighten it just a hair. Reliax, I've used Reliax for years. It's very good veneer luting composite. Push that to place. Don't wipe off the excess. Let me say this again. Do not wipe off the excess. Cure it for about a second on each side so that the consistency of the excess luting composite is about like crunchy snow. Then you're going to come back and peel it off. See, just for a second, just for a second. Then you're going to peel it off. The reason you peel it off and don't wipe it off is because there's always a micro gap between the restoration and the tooth. It may be 25 microns if it's a good veneer crown. It could be greater than that if it's not so good. Bacteria is 8 microns in diameter. So if you wipe the excess luting composite off, you're going to get some suck back out of that microgap, and you're going to get a void in the microgap. Bacteria, plaque will get into the microgap, and you'll end up with red, inflamed, swollen gums. So never wipe it off. Wait till you have initial set and peel it off. You want it to be about like crunchy snow. See, it's peeling off, and that creates a sandwich in that microgap, so there's no void. You're going to floss it, clean it off. You can also take the flat end of an amalgam carver and wipe the facial surface of the veneer and remove any excess luting composite or primer adhesive that's on the facial. Now I'm going to come back and cure both sides of the veneer 60 seconds. That's probably overcure. You probably don't need to cure it that much, but you cannot overcure composite. You can undercure it. So I'm going to cure it 60 seconds on the facial and 60 seconds on the palatal. Then I'm going to use this large, fine chamfer diamond to remove the excess luting composite on the palatal. You can see what a nice shade that is. Check the occlusion. This is a Shofu rubber wheel I use for final polishing of the palatal side of the restoration. So there it is. In my book, that's very good. This is before and this is after. Before, after. And it really does look good. I mean, it really does look good, because he didn't want to go through his life having that dark tooth. So this is very presentable, very close. I don't think anybody would know that that wasn't his natural tooth. That's the Dental Minute. These techniques work, and they work every time.
Are you feeling stuck? You know you have more to offer and you can elevate higher in your dentistry practice, but you just don't know how to do it? Well, great news. DentistryMasterclasses.com is here for you. At DentistryMasterclasses.com, Dr. Cutbirth is offering his greatest work and his best cases. Here's everything included when you subscribe to DentistryMasterclasses.com. You will get incredible comprehensive cases not seen in Dental Minute videos, an organized library of all the Dental Minute videos, and the Dentistry Masterclasses, comprehensive cases for study and reference. You will get before and after pictures of Dr. Cutbirth's fantastic restored cases. And guess what? All of this is $40 a month. That's right, $40 a month. This is an opportunity you cannot miss. Go to DentistryMasterclasses.com and subscribe today.